Hello everyone, and welcome to Bundling and Global Post-op Navigating the Issues. So glad you're joining us today. We're going to be talking about these issues and how to navigate all of the rules, how to find the resources that you need, and then how to appropriately do your coding in relation to these rules. Our learning objectives for today are going to be to define bundling and unbundling, to identify sources of bundling rules and how to interpret them, to appropriately append modifiers to address bundling edits, to define the global post-op period, identify services that are included in the global surgical package, identify services that are not included in the global surgical package, and to appropriately append modifiers to address global billing rules. Okay, so first we're going to be talking about bundling. Bundling is when a unique CPT or HCPCS code is included in the work described in another CPT or HCPCS code. When two codes are bundled, in general, they're not expected to be billed together. So what we're talking about is usually a rule that an insurance company that's paying you is going to impose upon you and say that you can't bill these two codes together. You've likely received some unbundling denials from an insurance company if you've been billing for a while. Unbundling is a coding error that takes place when two bundled CPT or HCPCS codes are reported separately. Or more specifically, it's an error that happens when they're reported separately without an appropriate modifier. So it can be an absolute error, or it can be that you did not append the right modifier to get your claim paid. Bundling rules can come from different sources, and the sources that we're going to be talking about today are the CPT guidelines, NCCI edits and guidelines, and payer policy or payer guidelines. So there's three different places that I have to be familiar with. I have to be able to look and see what's going on. Can I report these two codes together? Do I need a modifier or do I not? And when is that modifier appropriate? That's going to be one of your key issues, is making sure that if you are putting a modifier on the claim, you're putting it on the right CPT and that that modifier is appropriate in the given circumstances. Otherwise, you can end up having some issues if, for say, you were to be audited by the insurance company. Okay, so the first bundling guidelines that we're going to be talking about are your CPT guidelines. CPT guidelines are going to be found in the CPT code books, and there's a lot of them. So I'm going to give you a couple of the most commonly missed or misunderstood CPT guidelines, and then we're going to talk about some more general rules for finding the rest of these, because they really can exist in any chapter, and they really can be attached to basically any code that you're trying to use. So the first CPT guideline that we need to talk about is surgical coding guidelines. Surgical CPT codes are a huge portion of the book. They encompass most of the CPT codes that we're using. And one of these guidelines that often get missed is the following. The following services related to the surgery are included in addition to the operation per se: local infiltration, metacarpal, metatarsal, digital block, or topical anesthesia. Now, that's not that whole guideline. You would need to go back into your CPT book to look at the rest. But when you're talking about having nerve blocks injected at the site of surgery, when the surgeon does that, they're included in the surgical service. We're not talking about the anesthesiologist doing the service. We're talking about the surgeon, him or herself. If they perform a local nerve block in order to perform that surgical procedure, major or minor, that block is going to be included in the surgical package, and it should not be billed separately. A modifier is appropriate if the block is performed at a different site. So for commercial plans, you're going to use modifier 59, or for Medicare and United Healthcare, you're going to use modifier XS. Some of your other commercial plans may be starting to pick up the X modifiers instead of 59, so you will want to ask your plans that you're working with if you're not sure which modifiers they expect. Do they want to see still the 59, or do they want the XS instead? So just keep that in mind, that all of your local anesthetic for surgical procedures is going to be included at the site of surgery when performed by the surgeon. Okay, and then I have another surgical coding guideline. This is another example, right? Some of the procedures or services listed in the CPT codebook that are commonly carried out as an integral component of a total service or procedure have been identified by the inclusion of the term separate procedure. The codes designated as separate procedures should not be reported in addition to the code for the total procedure or service of which it is considered an integral component. When a separate procedure is carried out independently or considered to be unrelated or distinct, it may be reported by itself or by appending modifier 59. So this is another one of those guidelines that you have to be familiar with. If you've ever sat and wondered why some CPT codes have the term separate procedure in parentheses after them as part of the CPT description, that's because the CPT book is telling you this rule is applied to them. So in general, an insurance company is not going to expect to see any CPT code that says separate procedure in the CPT description reported with another surgical CPT code on the same date of service. Does that never mean that you can never ever bill it with anything else? No, of course not. But it means that I need to be able to append a modifier in order to say that it's separate from my other services for some reason. In general, they're going to be expecting you to be able to support one of the following reasons that we have bulleted out for you here: a different session or encounter, a different procedure or surgery, a different site or organ system, a separate incision or excision, and a separate lesion or injury. The one that I think is the most confusing for a lot of people is different procedure or surgery. And basically what we're talking about here with the separate procedure designation is that different procedure or surgery, you're going to use that one when we're saying we do not typically perform this service with the other, and it is not typically a part of the other. You're going to have some trouble with this one most likely. The insurance company is going to give you a hard time. You can provide documentation to sort of support what you're saying, but if you're talking about two procedures at the same site during the same encounter using the same incision, and one of them is designated separate procedure, you're going to have a very hard time supporting the idea that it's just a different procedure or surgery. I'm not saying it's impossible, but that one's going to be a little bit difficult to support. So if you can, you definitely want to use one of these others instead. It's a different session or encounter, site or organ system, incision, excision, or separate lesion or injury. Now there's lots of other places in the CPT book that I need to be able to look and make sure that I'm not unbundling codes inappropriately. There are chapter or code specific guidelines that you want to be familiar with. You want to definitely check the chapter guidelines when you're assigning a CPT code, and you definitely want to check for those code or section specific guidelines as well. The first one that you want to look out for is one that says do not report with. If you have a CPT instruction that tells you not to report one code with another, then in general you should never report those two codes together. It would be a very rare circumstances where, for instance, the patient has one procedure, leaves, and then comes back later with a different problem and has the other, when you would report those together. Again, that one's going to be very difficult to get the insurance company to understand. I'm not saying it's impossible, but in general, do not report with means I'm not supposed to put those two together ever. Includes. If you have an instruction that says includes, then in general, those codes should not be reported together. So what I'm saying is, whenever I have a CPT code that says it includes such and such other services, those other services are always going to be included in that CPT code, and I would not also report them separately. You can use a modifier if they're performed, for instance, at a separate site, and again, you'd use the 59 or the XS modifier as the insurance company requires. Okay, so as we're looking at specific CPT codes, we want to also make sure that we're paying close attention to the CPT's description. All items listed in the description of a CPT code are included in that code, and they should not also be reported separately. Some CPT codes contain an option that include an additional component and an option without. So I have an example of that here. Arthrocentesis, which is where the provider is placing a needle in a joint and either injecting a substance like an anesthetic or withdrawing fluid from that joint. And I have two options here. I have 20610, arthrocentesis, aspiration and or injection, major joint or bursa, without ultrasound guidance. And then 20611 is arthrocentesis, aspiration and or injection, major joint or bursa, with ultrasound guidance, with permanent recording and reporting. So if I have a provider who's performed an arthrocentesis procedure who is using ultrasound guidance for that procedure, I can't report 20610 plus my ultrasound guidance code 76942. That means that I'm unbundling those services because there's a CPT code that includes them both. So instead I want to report that using 20611. So if you've done this by mistake and you have some denials, the way to fix that is to change them to the 20611 and resubmit to the insurance company. So I want to make sure that I'm not only paying attention to the section guidelines and the chapter guidelines, but also that specific CPT code's description to make sure that I'm not unbundling things in error. Okay, now the next and probably the most extensive source of bundling guidelines is NCCI, which stands for National Correct Coding Initiative. At the end of this presentation, we have a resource page with some hyperlinks for you. I've provided the hyperlinks so that you can download the NCCI edit spreadsheets. You can download the NCCI manual, and you can also see some articles from CMS that I'll tell you about that you really need to be familiar with before you start really diving into specific issues that you're having in your practice. So NCCI edits are created by the National Correct Coding Initiative. It's a reference sheet of CPT codes that are not expected to be routinely billed together. So this is created by CMS. It's published on their website. And basically what I have is a very long spreadsheet. In fact, there's a couple. It's divided up by CPT range because the files are so large. And edits on the reference sheet contain basic information regarding the rationale and a modifier classification for the edit. So if I have two CPT or HCPCS codes that appear next to one another on that spreadsheet, then my general information is that they're not expected to be billed together. And then I'm going to have an extra piece of information that tells me whether a modifier is allowed or not allowed. If a modifier is allowed, then I can bill my CPT or HCPCS codes together if the modifier is appropriate. If a modifier is not allowed, then I may never ever bill those two together, no matter the circumstances. I have tried in the past when I had some really outstanding circumstances. For example, the patient left and then came back on the same day and had two different procedures that had a modifier not allowed relationship. I have never been able to convince any insurance company to pay them, no matter the circumstances. They simply look at it and say it's not allowed at all. So I think that one is, in general, kind of a lost cause. You certainly could appeal that if you feel like you have a really good ground to stand on. But I think in general, we're going to say that I can never bill those two CPT codes on the same day ever. There's also an NCCI manual, and it contains additional rationale for certain edits. So we're going to talk about that one as well. So to use the NCCI spreadsheet, which you can download from the CMS website, you're going to get a big Excel file. And what you're going to do is use Control F to open the Find feature in the Excel file. If you want to just search a particular column, which is what I like to do, select the column first and then do your search so that you only search that one column for the code that I'm looking for. Locate the first code I'm using in column A, or the NCCI manual actually calls it column 1, and then look for the second code in column B or column 2. Then I look up the second code in column A and check for the first in column B. So I have to look both ways to see if they exist side by side in either place. And then repeat for any additional code combinations you're using. So we actually have an example here, so we can show you these instructions, and then you can print out this slide so you can do them step by step. But I think it always helps with something this complicated for you to actually see it in action. So here we go. Okay, so here we are on our spreadsheet. Click that column A so that you can highlight just that column. Then use your Control F. Type in the CPT code you're looking for. There's our arthrocentesis 20610. It takes it a minute to find it because there are, as you can see, so many lines. But there I am. It's jumped me down to 20610. And then I'm just going to scroll down until I get down to the code that I'm looking for. So here we are, 76942. That's my ultrasound guidance code. You can see that it says I'm getting this edit because the CPT manual or CMS manual coding instructions, and I have a number 1 in column F, which means that the modifier is allowed. So I can use a modifier with this combination. For example, if I were using ultrasound guidance for a procedure at another site, then I might end up using the arthrocentesis code without ultrasound guidance and then have to bill my separate ultrasound guidance for guidance at another site. Then of course I'd be expecting a second surgical CPT code to go with that ultrasound guidance code. Okay, so interpreting the results of a CCI check. If the codes are not paired in column 1 and column 2 on the spreadsheet, then no conflict exists and you may bill the codes separately. And I put in parentheses here, as long as no other guideline exists. So just because I have something that doesn't appear in NCCI edits, it doesn't mean that I can definitely always bill those two codes together. If, for instance, there's a CPT guideline or the insurance company I'm working with has their own guideline, then I still might be in some trouble, but I at least know that I don't have an NCCI issue. If the codes are paired, then I need to check column F and see if a modifier may be used. So again, I gave you those values. Value 0 means a modifier is not allowed. I can never bill those two codes together on the same day. Value 1 means a modifier is allowed, which means that if appropriate, I can put a modifier on one of my codes and bill them together. If a modifier is allowed, which CPT code do I put the modifier on? That's always a question that I get, and the answer is put the modifier on the code that appears in column 2. A lot of people think that I'm always putting the modifier on the one that's worth the most money or the one that has the most RVUs. In general, it tends to go that way, but that's not always the case. So if you always want to put the modifier on the right CPT when it's appropriate, the modifier goes on the column 2 code, not the column 1 code. And then just some reminders about NCCI edits. NCCI expects you to follow CPT guidelines and assign the codes appropriately. So they're expecting you to know things like a nerve block performed at the surgical site is not separately billable from the surgery. They're not going to give you a CPT to CPT edit on every single one of those relationships. You're just expected to know that already. So just because a code-to-code edit in the NCCI file isn't there doesn't mean that the codes are appropriate to bill together. You still have to know all your other guidelines and be familiar with that as well. I do want to go back for just a second and talk about the modifier designations. You have designation 0 and 1. There is a third designation. It's a designation 9. And this is one that you're probably not going to come across very often. But designation 9 means that that code-to-code edit has been retroactively removed. So you should not have to append any modifier to that relationship. And every once in a while, I have an insurance company that has some trouble catching up to the NCCI rules, and I will actually print that file out for them. just, a page of that file, and show them the number 9 designation in the modifier field so that they can update their system and pay us appropriately. 9 basically means that relationship should never have existed, and I should be able to build the codes together without a modifier. Okay, so I also have the NCCI manual. We do have a link for you on the last slide of this show showing you how to get to the NCCI manual. It's broken down into chapters corresponding to the chapters in the CPT book. There's a rationale for a lot of NCCI code-to-code edits, but not all of them. So you don't always have an explanation for why NCCI says 2 codes should not be billed together. Sometimes the edits make more sense than others, but you do have a rationale for certain things, and it's really important for you to be familiar with the material in this manual because it's basically an instruction guide that tells you how to use those code-to-code edits. And if there is a rule that's clearly explained in the NCCI manual, it's going to tell you when or if a modifier is appropriate and under what circumstances that modifier can be used. So I want to make sure that I'm very familiar with the material that exists in the NCCI manual so that I have that extra information. The payer might need a copy of the special instructions given in the manual in order to correctly process a claim. I have come across this issue where I have an NCCI code-to-code edit. There's a specific rationale given in the NCCI manual, and it's usually the commercial plans that have some difficulty with NCCI edits and how to correctly process them. I have had to print out pages from the NCCI manual and send it in along with my claim so that they can see what the rationale is, why the modifier is appropriate in this given circumstance, and why it is supported by the medical records. So really important material in that NCCI manual. There's also information in there about some of the global post-op stuff that we're going to be talking about, and there's also information about medically unlikely edits, or MUEs. We're not going over those today, but I will be doing a video on MUEs in the next couple of weeks. They can be very difficult to understand and interpret unless you have all the information. That information is almost entirely contained in the NCCI manual. There's a separate section for MUEs in every chapter. That's really important to read and be familiar with. Okay, so next we need to talk about payer policies and guidelines. Usually when you're looking at this kind of an issue, it's because you've already looked at all of the CPT information, you've already done your NCCI check, you've sent in a claim that you thought was okay, and now you're getting something back from the insurance company saying that they believe you're unbundling codes inappropriately. I usually do a second check to make sure I didn't miss anything, but if I'm looking and there's nothing in the CPT instructions, there's nothing in NCCI, and I'm still getting a denial from that insurance company, then I know what I have on my hands is a payer policy or guideline that specific insurance company has created, and then I'm going to have to look and see what their guidelines are and deal with that. If I'm contracted with the insurance company, part of that contract is going to have to do with me agreeing to follow their policies and guidelines. So I can't just say you're not Medicare, I don't have to do it. I have to look at their guideline and then figure out how I'm going to comply. So I'm going to first search the payer's website for any policy that's provided in writing. I want to look and see if they have what they like to call medical coverage guidelines on their website published about the specific service that I'm billing. A lot of them are there. There are a lot of payer-specific policies about certain procedures where they'll say we don't pay for guidance separately with this one, or we don't pay for this one with that one. So I want to look and see, is there a written policy somewhere that I need to look at and determine whether I'm stuck on this one or not. If I don't find anything, then the next place I'm going to go is to the online claim reconciliation tool, if they have one, to research code edits. A lot of the bigger companies like Blue Cross and Blue Shield will have a claim reconciliation tool where I can go in and put in my 2 CPT codes and not only get information about whether they would deny those 2 codes billed together, but also their rationale. Availity is one that we use for Blue Cross Blue Shield of Florida and a couple of other payers, and it has some pretty robust claim reconciliation tools where I can go in and see exactly why do you think it's inappropriate to bill these 2 codes together in general. To resolve the denial, I have to address the specific logic that's given in their policy regarding the relationship between the 2 codes. So I need to be able to look at their policy, figure out what they're saying, why do you think these 2 are inappropriate together, and then I've got to look at my patient's record and make a determination, does my situation fit this guideline or is it something else and I should be putting a modifier on there. If I still can't find the source of the problem, so I've looked everywhere, there's no CPT rule, there's no NCCI code-to-code edit, there's nothing in the NCCI manual, I can't find a policy that this particular insurance company has, and I also can't find any sort of claim reconciliation tool that tells me it's not okay, then I probably need to just call them up and ask them what the issue is and why I'm receiving an unbundling edit. It could be an error on their part, or it could be something else and I'm just having trouble finding it. So it's always really important to communicate back with the insurance companies you work with and figure out what they're trying to tell you. Okay, so now that we understand all of the bundling guidelines, or at least how to identify them, interpret them, and where to find them all, the next thing I need to know is how to use modifiers appropriately. There is a link on the last slide in this presentation about where to find an article that CMS has published and republished multiple times about appropriate use of the 59 modifier. It's a really good article to thoroughly read through before you start appending modifiers because it really breaks down their expectations. And just for the record, I'll go ahead and tell you that all of the other insurance companies you're going to work with are going to have an expectation for you to follow these same NCCI rules and the CMS rules that they have outlined. They're going to point back to this documentation, so it's really important to be familiar with. And I've put on here some of my, top reasons that people tell me over the years, why did you put a 59 on this CPT code? And these are inappropriate uses of the modifier. So these are situations where it's not okay. This can't be a reason for me to use one of these modifiers. I need a better reason. Now, I'm not saying that you don't have a better reason. I'm just saying you need one and not one of these. The CPT codes are different, therefore they must be separate. The whole idea of bundling and unbundling is that we know there are many, many CPT codes, and the idea is that sometimes one does include another, so just because I have 2 different CPT codes or HCPCS codes doesn't mean that they're always separate and I just put a modifier on one. The second reason is the provider told me that he or she wants to bill both. Definitely not okay to start putting a modifier on those services because the provider said, no, I want to bill them both. I have to have a better reason than that. There's no other way to bypass the edit. So this is one that's going to get you into big trouble, right? I don't want to say, well, I just need to get the claim to go through, so 59 is my magic modifier. It's a magic modifier that gets you into trouble on an audit, so I don't want to just put it on there just to get my claim to go through. I do not want to write off the charge. This is one I hear a lot when people are working denials. I understand nobody likes to write anything off, but if I look at something and decide, the claim truly is unbundled, it's inappropriate, I can't justify a modifier, I need to go ahead and write off that charge rather than trying to shove a modifier on one of my CPT codes and force that claim through and get paid for something that really I've already been paid for via another CPT. I feel strongly that the procedures are separate, though I cannot explain why. Now, this is one that I hear a lot, and usually when somebody is saying this to me, they're 50-50, at least, I would say, correct that the modifier is appropriate. But I want to make sure that the coders who work for me, that my coders are able to really explain why are those procedures separate in clear terms, because chances are I'm going to have to explain that again to the insurance company. So I want to have a clear picture in my head of why they're separate, not just I feel like they probably are. Or we've always done it that way. We always put a 59 on this CPT combination. That's a bad situation to get into, because that tells me not only do you not have a reason for putting it on there, but that you're systematically appending modifiers, maybe inappropriately, maybe not. We'd have to look at it, but that's a dangerous situation to be in. So I don't have an always or never encoding. I don't have a situation where I always put a 59 when I have this CPT with that one. I have to look at the specific scenarios for each patient and determine why is that modifier appropriate. And here are my good reasons for using these modifiers. And so I gave you the list of all of them: 59, XS, XE, XP, and XU. Number 1, the procedures are performed at separate sites, operative fields, or separate lesions. That's a great reason to have your 59 modifier, or that would be the XS for separate site, separate operative field, separate lesion. The procedures are performed during separate encounters. For example, a return to the OR later the same day. That's going to be your 59 or your XE modifier. The procedures are performed via a separate incision. So sometimes I have 2 approaches that have to take place or something of that nature. That one's going to also be an XS or a 59. Or the specific service meets the specific criteria described in the NCCI manual that allows a modifier. That one's going to be your XU. The XP modifier is actually for separate physician. I haven't yet come up with a good use for that one. I have tried to use it a couple of times and the insurance company did not like it. So I'm still trying to come up with an example on how to use the XP modifier. But these are your really good, solid reasons for using these modifiers. And if I'm going to consider using them for one of these reasons, also another more descriptive modifier like left versus right doesn't fit the given scenario. So if I can use a left-right or your finger or toe modifiers instead, then I definitely want to do that and be as specific as possible every time I code and every time I append a modifier. Okay, so now we're moving from bundling into the global post-op period. If you want to take a break, then this is a good time to just pause the slideshow, take a break, and when you come back, unpause, and we'll be right here talking about global post-op. Okay, so when we're talking about the global post-op period, certain services are included in the global period or the surgical package of a surgical CPT code. And you're talking about almost everything that exists in the 1,000 or 10,000, excuse me, to 60,000 CPT series. All those sections, almost all of those CPT codes are going to have what we call a global period and a surgical package. Surgical CPT codes are assigned a number of days by CMS during which these services would be expected to be performed. The most common problems coders encounter are an evaluation and management service on the same day as a minor procedure, an evaluation and management service on the same day or the day before a major procedure, an evaluation and management service during subsequent global days for a procedure, and procedures during subsequent global days for a procedure. So we're going to talk about all of these scenarios, where to find all of the rules that we're having to follow as they pertain to the global surgical package, and try and figure out when I can bill separately, when it's included, and how to use modifiers to get those claims to go through with the insurance company. Okay, so when I'm talking about global days, minor procedures have a global period of 0 or 10. It is really important to be able to identify minor procedures versus major procedures given the global days. And the reason that's important is because the rules are going to change depending on whether I'm dealing with a minor procedure or a major procedure. So minor procedures have a global of 0 or 10. A global of 0 does not mean there is no global procedural period. What a global of 0 means is that day of the procedure is the global period. So it's D-Day, it's day 0. The day of the procedure is the global day. A procedure that has 10 global days is the day of the procedure, remember that one's day 0, plus 10 days after the procedure is the global period. Major procedures have a global period of 90, and that's going to include the day before, the day of, and 90 days after the procedure takes place. Services provided during the global period of a procedure must be reviewed for an appropriate modifier. If the needed modifier is not appropriate in the given situation, the service should not be separately billed. So we want to make sure that we understand how to use these modifiers, when they're appropriate, when they're not. And I'm going to be reporting a global post-op visit or something similar if I'm providing services during the global period that I cannot justify a modifier, which means they should not be separately billed. I can find all the global days for a CPT code in the Medicare Physician Fee Schedule. So you can actually download that. There's some online lookups that you can look up. If you're using an encoder, it probably has the global days that you can look at. I want to be able to make sure that I'm interpreting these rules given whether the procedure is a minor or a major procedure, and that I know how many global days are attached to each surgical CPT code that I'm using. Before we continue any further talking about the global period, I do want to point out that there is some documentation, in particular in the Medicare Claims Processing Manual, which we've given you a link to on that last page, that talks about scheduling patients purposefully to avoid global billing rules. And of course, you're just aching to hear me tell you that's really not allowed. So if I'm in a situation where a provider is asking me, what if I just schedule all my pre-ops 10 days before the surgery? That's not appropriate. It's still a pre-op visit. It still should not be separately billed. And now you're routinely scheduling your patients 10 days out in order to avoid the global post-op billing rules. And that's kind of a major problem for you from a lot of different perspectives, like a patient safety perspective, compliance perspective. So I want to make sure that I discourage those behaviors and make it clear that services that are expected to be performed as part of that surgical package, whether performed during or after the global post-op period, really should be included in the surgical package unless they occur after the global period is over for some specific reason. And if it's happening all the time, then as a general rule, I'm going to have some trouble explaining that. I don't want to routinely schedule patients for pre or post-op visits outside the global just so that I can separately bill those visits. It'll probably pass through for a while, but ultimately that one's going to get you in some trouble. So you want to definitely avoid and discourage that behavior. Okay, so let's talk about evaluation and management services on the same day as a minor procedure. This information is contained in the NCCI manual, which we were talking about earlier, and it does contain a lot of very specific information. Now, I know that there is some information in the CPT book about billing, evaluation, and management services on the same day as a procedure and using a 25 modifier. The reason that I've included the NCCI language here is because it is more specific, it is more restrictive, and almost every insurance company is going to expect you to follow this rule. So if I have a rule that's a little less strict than the other one, I have to follow the stricter rule. do what it says, make sure I'm complying with this, or I'm just going to get my claim back anyway. So here is the rule. In general, evaluation and management services on the same date of service as the minor surgical procedure are included in the payment for the procedure. The decision to perform a minor surgical procedure is included in the payment for the minor surgical procedure and should not be reported separately as an evaluation and management service. However, a significant and separately identifiable evaluation and management service unrelated to the decision to perform the minor surgical procedure is separately reportable with modifier 25. The evaluation and management service and minor surgical procedure do not require different diagnoses. That is a very important point. You don't have to have different diagnosis codes. If a minor surgical procedure is performed on a new patient, the same rules for reporting evaluation and management services apply. The fact that the patient is new to the provider is not sufficient alone to justify reporting an evaluation and management service on the same date of service as a minor surgical procedure. So what this is really telling us is that in order to bill an evaluation and management service plus a minor procedure on the same date, I need the medical record to show that the patient was evaluated and managed beyond simply determining the need for the procedure and the typical pre- and post-procedure care. So I gave you some really great examples of when we would say separate E&M, same diagnosis. Workup to rule out additional disease or injury. And CMS actually gives us some really great examples of this. The example that they like to use is a patient who comes in with a head laceration. If the provider simply says, yep, you have a head laceration, stitch it up and send them on their way, maybe put some bandages on it, that is not a separate evaluation and management service. However, if the provider also performs a neurologic exam to make sure that the patient doesn't have a concussion because they have a head injury, now I have a separate evaluation and management service. So workup to rule out additional diseases or injuries beyond just the immediate problem I'm treating with the minor procedure would justify a separate E&M service on the same day. Use modifier 25. Additional management of the underlying condition. For example, prescribing drugs like antibiotics after draining an abscess. That's a separate evaluation and management service. Perioperative antibiotics are going to be part of the surgical package. And so if you're not familiar with what I'm talking about, essentially there is some standard of practice in a lot of places where I would provide the patient with antibiotics prior to performing a procedure to prevent operative or post-operative infection. Administering and prescribing perioperative antibiotics to prevent infection from the procedure is part of the surgical package. Prescribing antibiotics to address the underlying condition, like your cellulitis that you came in with, would be considered separate. And then, of course, treatment of additional complaints that are unrelated to that procedure would certainly be considered separate. If a significant and separately identifiable E&M service is performed, use modifier 25. Okay, now we're going to talk about evaluation and management on the same day or the day before a major procedure. So this is a procedure with a global of 90 days. Per the NCCI manual, so we're going back to that manual to talk about this rule. This is where we find the most clear and extensive description of the expectation is in that NCCI manual. If a procedure has a global period of 90 days, it is defined as a major surgical procedure. If an evaluation and management is performed on the same date of service as a major surgical procedure for the purpose of deciding whether to perform this surgical procedure, the E&M service is separately reportable with modifier 57. So this is a big difference from my E&M with a minor procedure. I just got told deciding to do the procedure is not a reason to bill a separate evaluation and management code for a minor procedure, but for a major procedure it is, and I even have a special modifier to use to report that, which is modifier 57, decision for surgery. Other preoperative evaluation and management services on the same date of service as a major surgical procedure are included in the global payment for the procedure and are not separately reportable. So doing a pre-op visit and checking to make sure that my patient's condition hasn't changed, that the surgery is going to be safe to proceed, that's going to be included in the surgical package. So the medical record needs to justify that the E&M service resulted in the decision to perform the surgical procedure. I'm going to use modifier 57. In the rare instance that an evaluation and management service is performed on the same day as a major procedure for an unrelated complaint, then I would use a modifier 25. You're probably going to have to provide documentation of that back to the insurance company. Try as you may to just put different diagnoses on them. You're going to have some trouble with that one, but that is actually the rule. It's found in the Medicare Claims Processing Manual and the NCCI manuals, so I want to make sure that I'm familiar with that rule. I use a 57 for decision for surgery, and I use a 25 if I'm actually doing an evaluation and management service for something different than what my surgery is going to be performed for. So the next thing we want to talk about is billing an evaluation and management service during subsequent global days for a procedure. So if my surgical procedure has a global of 0, I really don't have to worry about this one because I'm only dealing with evaluation and management same day. If I'm dealing with an evaluation and management during that 10 or 90 days post-op that's included in some CPT codes, then I need to know these rules. Where these rules can be found is in the Medicare Claims Processing Manual. We have a link for you on the last slide of this presentation so that you can download that whole thing. It's several hundred pages, so I did reference the specific sections that you should look in for these rules. What's included in the global period? Things that are included, which means they're not separately billable. Evaluation and management services related to recovery from the procedure. So standard post-op checks and things like that where I'm just making sure that you're doing well post-op, that's going to be included in my global surgical package, and it should be reported with 99024, which is global post-op visit. Evaluation and management services related to complications from the procedure. This is a big misconception in medical billing and coding. A lot of people think that I should be able to bill separately if the patient has an unexpected complication. In general, that is not going to be allowed. Evaluation and management related to complications from the procedure are going to be included. It is my job to make sure that my patient recovers, including recovering from any complications related to that surgery. Dressing changes, suture and staple removals, urinary catheter exchanges, and wound rechecks are all included in the global post-op and should not be billed separately. Now let's talk about the good news. What is not included in the global period? So these are the things that I should be billing separately for. Evaluation and management services for unrelated complaints. So of course, if my patient comes back, they have an unrelated complaint to the surgery, that one's going to be a separate evaluation and management. Evaluation and management services for ongoing treatment of the underlying condition. So if I've performed a surgery, but I'm still having to treat that underlying condition, for example, I'm doing chemotherapy planning after excision of a tumor, those services are also going to be considered separate. There is one thing I'd like to point out, which is inpatient services. So if I have a patient who has been admitted as an inpatient to a hospital for their surgery, from admit to discharge, all of the evaluation and management services for the reason that caused the surgery are also included. So I have to get post-discharge before I can bill separately for treatment of the underlying condition. That information is also in the Medicare Claims Processing Manual, Chapter 12. If the evaluation and management service is one that's not included in the global period, so unrelated complaints, ongoing treatment of the underlying condition, append modifier 24 to your evaluation and management E&M code. Now, sometimes I'll have a patient come back for evaluation and management, and part of what we're doing is a post-op recheck, and part of what we're doing is treatment of the underlying condition or treating unrelated complaints. And so what I encourage my providers to do and what I encourage my coders to do is sort of divide up which portions of that visit pertain to things that are included in the global, which portions pertain to things that are not, and probably end up with a lower level of evaluation and management because I've carved out the portions that are included in the global, and then I put my 24 on what's left. If the evaluation and management service is part of the global period, so one of those top three things, then I use CPT code 99024 to describe the E&M service. I should not have a dollar amount assigned to that CPT code. It should be $0 because it's included and it's not separately paid. Do note that CMS started requiring us to report post-op visits 99024 for only certain surgical services. There are lists out there on the website. I do report them just for everything because it's not a bad thing to be in that habit. So that way, if they update their list, which ones do I have to report, which ones do I not, I'm not worried about it because I'm going ahead and reporting my post-op visits for every single surgery that we do. Okay, now we're talking about procedures, surgical type procedures performed during subsequent global days for my first procedure. In general, additional surgical services are going to be separately billable, but they may be subject to multiple procedure payment reductions. So just like if I bill 2 surgical CPT codes on the same date of service, I get paid 100% for the first one, half for the second one. I may be taking half a payment for a surgical service performed during the global post-op period, depending on the modifier that I append. If you don't put a modifier, you're just going to get it back as a denial, so you might as well go ahead and figure out which one is appropriate. Based on the situation described in the medical record, I'm using a 58 for a staged or a related procedure during the global period. This modifier does get misunderstood quite often, I think. It's for a staged procedure, meaning that when I did my first surgery, of which I'm in the global, I planned on coming back and doing this second stage procedure, be it major or minor. That one gets a 58 modifier, no matter where that procedure is performed. If I planned it in advance as stage 2 or 3 of this service, that's a staged procedure. Or a related procedure. So just because I didn't plan it ahead of time, if it's related to my first procedure, I'm going to go ahead and bill it with a 58. Unless it's an unplanned return to the OR or the procedure room. That one's going to be a 78 modifier. Now, I do get asked quite often, when do I use the 58 and when do I use a 78 for a related unplanned procedure during the global post-op period? The answer to that lies right in the description of the 78 modifier. If I have to take the patient back to the operating room or the procedure room like the IR suite or the cardiac cath lab during the global period, that one's a 78 when it's unplanned. If I have to do a secondary procedure or an unplanned related procedure in the doctor's office or some other location that's not the OR or procedure room, I'm using a 58. And then I'm also using a 58 for a staged procedure. So the real kicker, the real difference with the 78 for an unplanned procedure is where the service happens. If I'm returning to the OR or the procedure room, it's a 78. Otherwise, it's going to be a 58. And then I have my third modifier, my 79 modifier for an unrelated procedure during the global period. In general, we're talking about a procedure that has nothing to do with the first surgery or the reason for that surgery. So it's going to be on a different site, a different organ system, and so forth. That one's going to get a 79. I don't want to use modifier 59 to manage global post-op issues because the insurance company is not going to be able to process that claim correctly, and I'm just going to get it back. So I want to really review that record and use modifier 58, 78, or 79 as appropriate, and I'm going to completely bypass my 59 modifier when I'm talking about procedures during subsequent global days. That one's just not going to work for me here. If I get a claim denial about a bundling or unbundling issue, the issue is that the payer or insurance company refuses to pay for my bill, and they're going to give me the reason that they've denied the services on the explanation of benefits. And so for these purposes of today's topic, we're talking about a denial that says you're bundling or unbundling, or you're billing for services that should be included in the global surgical package or part of the global post-op period. It's my responsibility as the coder to make sure that the payer's guidelines are being met and respond appropriately to the denial. So most denials occur because the charge wasn't coded appropriately to begin with. The one that I see the most often on these is that I forgot to put the right modifier. Putting the right modifier on or fixing whatever other coding errors might be present at this point might fix the issue, but often once I've received a claim denial, I'm going to have to go back probably and provide documentation to support my claim, to explain why I'm saying this modifier is now appropriate. So I want to be prepared to do that. And what I usually do is I take a big dark pen and I really underline or circle any portions of the record that really point out what I'm saying about why my modifier is appropriate, why my CPT codes are separate, why it's not part of the typical global post-op package, so that I can get them to understand where I'm coming from and get them to turn around and pay that claim for me. Okay, so here's our resources page that I keep promising I'm going to give you. Just a few hyperlinks. They all link you back to the CMS website. That's a really great website if you're looking for coding guidelines, rules about when to use modifiers, all kinds of great information there. Again, most of the insurance companies that you're contracted with, that you're working with, are going to have an expectation that you follow the CMS guidelines. They're going to tell you in their contract as a general rule. They're going to toss those guidelines back out there at you when you're trying to talk to them about denials. So really important for me to know where to find this stuff, how to find it, and how to give some of that documentation back to them if I'm getting questioned about my interpretation of those guidelines. So guidelines for global surgical billing are in the Medicare Claims Processing Manual, Chapter 12. Look in sections 30.6.6 and section 40, and there's your link to the Claims Processing Manual, Chapter 12. The NCCI Procedure to Procedure Edits file. What you're going to get is you're actually going to get a zip file that's going to contain the spreadsheets. There's a lot of different links. If you're doing physician coding, then you want to download the practitioner edits files. There's a big list. And they're also in there by the dates that they're effective. So you want to use the version for the date of service you're dealing with. The NCCI manual, all chapters, can be downloaded at that next link. And do be aware that the NCCI manual gets updated every January. So in January, I want to download that manual again and look for the text that's in red. That is the changes that have been made to that manual. I want to review for changes every year. CMS instructions for appropriate use of modifier 59. This is an excellent, very informative article. It's one that I want to be familiar with because it really outlines the CMS expectations for how I would use that modifier, and it also talks about the X modifiers as well. So definitely click on that link, take a good read over that article, and make sure that you're familiar with those expectations. And then this last one is the CMS instructions on using NCCI resources. This is a really nice article that explains how to use the procedure to procedure edits file. It's really very informative. So if you have trouble remembering which column to look in and things of that nature, it really breaks it down for you again. So it's a very nice resource for you as a coder or as a provider to open that up and look at those instructions and know how to use those NCCI CPT to CPT relationships. I'm really hoping that you've enjoyed our webinar today. I hope that you learned a lot. Do let us know your feedback, what you learned, what you'd still like to know about, so that we can do some updates if you think they're necessary. And thank you so much again for joining us. Have a wonderful day and have fun coding.